We're going to get into the most interesting piece now. At least I consider it the most interesting piece, right? We're going to get into online analysis. And in here, we're going to be able to do any slice and dice of the data that you might want to do. So this afternoon, what I'm going to ask is, as we get into various sections, if there's something somebody's interested in doing, let's bring it up. Let's see if we can't do it on here. You all have access to WIO now if you have a login, right? And you'll be able to actually duplicate everything that we do up here. And you can then save it as a template to your own My Reports section. So we're going to go through provider network assessment again from a slightly different viewpoint, cost and use, and population and care management. Population and care management is that area in which you can actually see your diseases and the cost that those diseases contribute to the entire population. So the first thing we're going to do is jump into provider network assessment. If you guys want to follow along, you can. But within provider network assessment, we've got morbidity adjusted cost, morbidity adjusted utilization, and cost detail. Now, everything in online analysis works in a very similar fashion. So if I went into physician episode here and I did morbidity adjusted cost, the first thing that you're going to see is you're going to see a set of dimensions and you're going to see a set of measures coming up into this area right here. So if you see this episodes, if you click it to go to plus, you've got dimensions and measures. We don't use named sets and KPIs, so you can just forget about those. But under dimensions, the dimensions that get shown here are very specific to the cube that you're in. So this cube is morbidity adjusted cost. So everything that shows up here are different ways of slicing and dicing cost. And when we go down to measures, all the measures are associated with different types of cost measures. So let's take a look at the measures. And you can see here we've got calculated measures, cost measures, and count measures. If it's cost and count, they're usually fairly short under here. And if it's under calculated measures, we typically have a lot of them. So when you're looking at the application and you're looking at what do I want to do with this, one of the things you're going to do is you're going to first say, well, what kind of a cube is it going to be in? Is it going to be in a network assessment type cube? Is it a cost and use overall type cube? Is it going to be in population and disease management? Once you've picked the cube, inside the cube, you're going to look to see if you have the dimension that you're interested in querying. So let's say, in this particular case, I'm interested in finding what types of episodes are driving your population costs. What I would do is I would go to ETGs here, and I would simply take ETGs and add those ETGs to a row axis. So it's going to pop them up over here. And you can see it starts with MPC. This is like one of the slides we did before. Now, if I wanted to drill into that, the little plus signs here indicate that we could actually go deeper. And in this case here, I'm just going to go one time through. Cardiology opens up to all of these families here. If I go in a little bit deeper than that, we're going to see it goes to the ETG level. And if I open up a little bit deeper than that, it goes to the actual severity levels. Now, some of the stuff flows off the end of the screen really quickly. So right now we're kind of locked off here. You can do one of two things. You can actually take this like a normal mouse and just kind of move it back and forth because you've got that right there. Or this is the quick way of doing it. Show it and hide tree schema. So now what we've done is we've actually gotten rid of the tree and we're looking at just the data. So I'm going to put that back and I'm going to drop this back to the high end. So we're going to see just the MPCs there. So the next question I'm going to say is, what's driving my cost? I'm going to take my total standard cost and I'm going to add it to the data area. And what that's going to do is it's going to put it all right in here.
Which one did you grab?
I draw total standard cost because everything, remember, in the WIO database has a standard cost to it. There's only a few things, Medicaid, that have the allowed cost. And build cost is there, but quite frankly, build cost is kind of useless. Nobody pays build charges.
And all of the indexes and measures, calculated measures, go off of the standardized cost.
Yep, absolutely. So what this has done is it's a great place to start a fishing expedition. That's the way I look at it anyway. I start looking at this and I start to say, okay, what exactly is costing me the most here. And so you can actually just look at it and you can actually pick it out. It's orthopedics here. Or you can actually sort that. These little upside down triangles that you see here, here, and here each have functions. So if you roll your mouse over one of those triangles and click it, you can see what the things are that you're allowed to do. And in this case here, you can sort it descending or ascending. You can do an auto percentage, which I just learned the other day. You can add an alert, add a measure. You can do a whole bunch of stuff with this. Now, if folks are interested in learning more about how this particular section of the product works, this is MicroStrategy. So if you just go out on the web and grab the MicroStrategy manuals, they tell you a lot more about how you can do things within MicroStrategy. But in this case here, let's say I just sorted it descending. Orthopedics comes up to the top. I want to find out what in orthopedics is driving my cost. Well, I can just open up the MPC to actually get some more details. And you can tell as soon as everybody started doing this, it slowed down.
Well, I'm going to send a monster query on it.
Are you? Okay, great, Duke. We appreciate that. Okay, so here we have it opened up to joint.
If I could ask one more question about
Yeah.
monster queries. So if I understand this, if I send one off and I go, oh no, and even me restarting my browser, that thing is still running. So
On the server.
So if I go back and run the second one again and go, oh no, and I keep doing that, I'm pretty much using up all the resources. So just getting out, you can't stop it.
No.
Okay.
Now, what'll happen at some point, it'll time out on the
Right.
server side.
Right.
Or, I mean, if it's like a really big emergency, we could probably stop it on our end, but we rarely, if ever, have had to do anything like
Yeah.
that.
Okay.
So now we're down to joint degeneration localized, and that's what's actually causing the big dollar value. I can actually go a little bit deeper, and I can identify what type of joint degeneration is causing it. In this case here, back with surgery, and then knee and lower leg with surgery. So I've identified some things here about the particular population you have that seems to point towards orthopedics as an area that you'd want to look at. So that's one way of looking at the data. Now at this point, I can do one of several things. I can either print it, I can send it to Excel, export to Excel, and that'll export only what you see on the screen here. Or I can go to where it says this pivot table dropdown. I can open up the pivot table dropdown, and I can do additional things here, including, you can see there's a new export to Excel here. That export to Excel will not only do the current page, but everything that's out there. So that's typically where folks end up going. Next, you can actually create a chart out of this data if you wanted to. So let's say, for example, I'm going to go back to the actual data itself, and I'm going to drop it, and I'm going to drop to the MPC level. And I'm going to now create a chart on this particular set of data. What happens is the chart comes up at the bottom and says, where do you want me to put the chart? On top, underneath, etc. What kind of a chart do I want, etc. I'm going to say OK, and it's going to create a chart of what we have at the top from orthopedics all the way down. Now the chart is an active chart. So if I were to drill into any one of these categories here, let's say orthopedics again, what's going to end up happening is the chart's going to actually reflect the drill within that particular area. You can create as many charts and pivot tables as you'd like. So for example, if you want to go up here, see this empty space up at the top here? See how the mouse changes when you go to the empty space? You guys might all want to try it. If you left-click the mouse there, you can add a new pivot table. You could add a new chart, and you can put different data on that. So what a lot of clients will do is they'll actually set this up where they have the data, the chart, the data, the chart. On the first one, they might have the high level, just the MPC. On the second level, they'll filter out just orthopedics and have a graph for that. Within orthopedics, they'll go down one more and say, just take joint degeneration localized and do a graph on that. So essentially, you've got as many, I guess, spaces on the graph here as you need to put a chart, a table, chart, a table, chart, a table. There is a limit at some point, but I've never run into it. Sure. If you go up to the little chevron right here next to pivot table, on the pivot table you want. Now in this particular case, you're getting all grayed out because there is nothing in that pivot table. But if I were to go down to this pivot table and I get to that chevron, you got the ability to create the chart. So let me show you what I mean by, cascading charts, if you will. What I'm going to do here is I'm going to go back and I'm going to put exactly the same information as I had on chart 1 up here. And I'm going to throw the ETG unit in here. And I'm going to throw in the total standard cost. And that's in this area here. And then what I'm going to do is I'm going to create a chart on that. Okay. So I've got my first set. And then what I'm going to do is I'm going to take the second one that has joint degeneration and such in it. And what I'm going to do here is I'm going to actually filter this MPC here by setting a filter, moving down, and only picking orthopedics. And I'm going to give you something to do in a second that does something pretty similar. So if you're not quite following along, hold on for a second. There we go. And then let's see. Yep, that's pretty close. Yep. So that's kind of what I wanted to bring out. First one gives you the big picture. The second one gives you just orthopedics down to the detail level down in this area here.
So how did you create that top window?
Okay, how did I create the top window? If you can see right in here, there's like little space where you move your mouse and it turns darker. If you right-click the mouse there, you can add a pivot table or web link or anything else that you wanted to. Okay, so for your first assignment, we're going to use this cost and use one. So we're going to stay right in this particular cube. And what you're going to find for me is you're going to find for me what the highest cost ETG is for ear, nose, and throat. Just picked it out. So see if you can figure out how to do that. And we're at the ETG level. And while you're doing it, I'll do a little bit, but I'm going to try to go really slow so you can't copy me. Everybody should know that ENT is oral laryngology, right? Okay. Okay, okay. I'm just checking.
Good question.
Don't be afraid to play with all the other features and functions that are there either. There may be a better way to do it, and there may be a best way to do it. Okay, are folks getting somewhere? Oh yeah, you got it. Oh no, that's interesting.
Is it?
Oh, I see, you do have it, it's just sorted different. Interesting. It's interesting to see how people go about it, because there's multiple ways of getting to the same answer, and I've already found 2 different ways of getting there, which is cool. Yeah, you're there too. Okay, this whole row has a way of getting somewhere close, so we'll see how you guys are doing. What did you guys get? Yeah, you got it. Yeah. Okay, you guys got it pretty quick, actually. So I did it a little differently than you guys did it, I'm pretty sure. You guys followed my instructions from the first time around, right? Here's a couple of tricks to get at stuff directly, rather than having to kind of actually drill down. I specifically said what things are driving ENT costs. ENT costs are what? Otolaryngology, right? So what I did was, instead of going in and saying, okay, get me all of the MPCs for otolaryngology and then do this, I said, let's filter it first. Let's filter it by the peer group of otolaryngology. See this right up here, otolaryngology? There's also a way to filter this. And what I did was, as soon as I put that there, I didn't filter this. You can see there's nothing in here but otal and endo. Those are the only 2 things that appear. So by filtering it, I got one thing there, not that whole list of MPCs with everything on it. I only got what these guys do. And yeah, chronic sinusitis is right at the top of the list. You guys all got there. You got there a different way, and that's okay. Yes, ma'am?
So my standard cost for chronic sinusitis is 136 million, and yours is only 36, so I'm not sure what I did. Your definition.
Yep. That's the difference, right? The difference is chronic sinusitis, right, can be treated by otolaryngologists, ENT docs. It can also be treated by who else? Absolutely, it can be treated by anybody, right?
Sure.
So that's why she's getting 136 million, but I specifically said ENTs, and I'm getting 36 million. That filter condition actually defines it. So you have PCPs treating it, you have a lot of people treating it, but ENTs, they treat only that piece of it. So how many people got the 136 million, and how many, first of all, how many got the 136 million? Okay, how many got the 36 million? Oh, so then it was a real trick. I thought some of you really got it. Okay. So you guys see, let me show you how to filter. Right up here on any of these, and I'm going to start from scratch, provider network assessment, episode, cost. So here we go. I'm going to go into my cubes. I'm going to go into my dimensions. Because I wanted otolaryngologists, I took this peer definition category here, and I said, put it into a filter condition. And then I said, let's filter it. Come down here, and I decided to filter on just that one called otolaryngology. Then I said, grab me all of my ETGs, add those to a row, and they're going to show up here. Only 2 things showed up. Why? Those are the only 2 MPCs that got attributed to an ENT doc. That's it. And then what I did was I added measures, and I added episode costs, total standard cost to the data area. Whoops, if I could do this right, to the data area. Drops it in there, and then I expanded endocrinology, which is like, wow, that's not really a lot. There's nothing there. And then I expanded otal, and here we go. And then acute sinusitis is coming up under the otolaryngology, so I'll make that smaller. And then we can just sort that in descending order, and you got the chronic. So the difference here was the difference between you guys selecting just the episodes of care, regardless of who the PCP or the provider was, and me saying ENT costs. ENT infers a peer group of otolaryngology, and that's what they're treating. So the extra $100 million, right, is being treated by lots of other folks. So now I'm going to twist this on its head a little bit. Can you tell me by peer group how much in each peer group is treating chronic sinusitis. So by peer group now. So you want to list this differently, and you want to have just chronic sinusitis. Let me give you a hint. You're going to probably want to take the MPCs here and switch them for the filters and put the peer groups down here. So you're going to probably want to reverse it a little bit. We're playing with a big pivot table, so it's pretty simple to do.
For you.
Oh, you'll get there too. And, so you work on that, and I'm going to just go through real quick and drop it on there. And then I'll walk through it slow. Yeah, that's what I usually do. I usually go back to the ground zero and start over. It's usually the cleanest way to do it.
You have to go over to online analysis provider network and go that way. Yeah, that's how I do it. By the, yes. Or well, you could just.
So you're walking your way through trying to put all of the peer groups on this side and chronic sinusitis on the top.
Well, I'm lost.
Okay, let's give it a shot.
We have this, what am I?
Okay, so you're in specialty level, first of all, and you're in cost and use instead of the correct cube. So if you go to provider network analysis, on the left-hand side, all the way over, right there, up, that one, physician episode, morbidity adjusted cost. That's where you want to be. The next thing you're going to do is open up the episodes, go to your dimensions, and now what you want to do is you want to put your, down the left-hand side of the pivot table, you want to put your peer groups. So you take that and you just, bring it to, there you go. And it's going to show up all the peer groups. Next thing you're going to want to do is you want to say, I only want chronic sinusitis. Well, that's an ETG. So I would put an ETG in there. No, I would click on the ETG. Yeah, any one of those, right? Click them. And I would put them in as a filter. And what that's going to do is drop it at the top.
Right, well, we played around with just,
Yep.
I'm struggling with navigation. So
Oh, yeah, that's what it, that's okay. So now, do a filter. Yeah, and just pick that one. So you want to drill down into the otolaryngology one, which is a little bit further. Yeah, there we go. And then you could chronic sinusitis, like the third one. There it is. Top. Yep. Say okay. Yep. And now take your measures and stuff your measures in there. And we had cost. Yep. Cost. Yep. Total standard. Yep. Add it to data. Boom. You're done. That's the 136 million you got. 28 million is being done by.
this part of
Okay. I'll go over that. I'll go over that. Everybody's getting it. This is good. Did you get it?
Got it. They're just in like a little different order. Oh, I just need to.
That's right. Sort descending. Bingo.
There.
Okay. Did you get it? Okay. Oh yeah, you got it. Yeah, and you have 136 million. Yep, that's it. Yep. Okay, so most people have it. I'll walk through it very slowly now to kind of show you how you got there, because there seems to be some issues with navigation within the system. So I'm going to start from scratch. First of all, when you're doing online analysis, the first thing you want to look at is which cube should I be in, right? Because we have three major cubes here: provider, cost and use, and population. But within those, we have minor cubes. In this case here, episode, and then we go to morbidity adjusted cost, morbidity adjusted utilization, and cost detail. Well, I'm going to go right into cost because that's what I'm interested in. And then what I'm going to do is I'm going to open up the dimensions. And the first thing I said was, let's find out which peer groups spend the most money for chronic sinusitis. So I can take and I can actually put the peer definition here as one of my rows, and what you're going to see is all of those peer definitions show up here. These are all the peer definitions that you have inside of WEO. It's about the 40 that we talked about. So these peer definitions include, at the moment, right, things that never have anything to do with chronic sinusitis, right? So for example, who would ever think a dermatologist or a chiropractic or a neurosurgeon would do chronic sinusitis, right? The reason that's there is because we haven't identified that we only want to look at one thing, chronic sinusitis. So the next thing we're going to do is like home in on chronic sinusitis. How do you do that? Well, chronic sinusitis is an ETG. So I can take this ETG, and if I right click it, I can make it a filter. So I'm only going to filter on it. So I'm going to click it, and up here it shows up. And then I click this and I can set the filter. Come down here. See how it's all checked off? I'm going to uncheck it. Come down here to otolaryngology. Open it up. There's my chronic sinusitis. I'm going to click it. What just happened to my table of 40? The only peer groups that are showing up now are those peer groups that have treated and been attributed at least one episode of chronic sinusitis. That's what happened. Now, I'm going to add my measure in, and we had cost as the measure, standard cost, into the data. It's going to show up here. Remember the 136 million folks we're getting before? That's right at the bottom. But if I actually take this and I sort it descending, which is the last step here, we now know who's treating these conditions, right? Which peer groups, what kinds of doctors. Who otolaryngology includes all of WEO, all the otolaryngologists, all the ENT docs. They're doing the bulk of it. Now, if you look here, and I'm going to ask you this question, so a question for the class, is $136 million the accurate number for the total dollars you've spent on ENT treating chronic sinusitis, or is that overstated or understated, and why? Remember how we talked about assigning episodes to peer groups, assigning doctors to peer groups? What do you guys think?
Over.
Why? You're right.
The second row looks like a subset of the first row.
Yeah, there you go. What's happening is here, this first row up here, all the same doctors are in some of these other ones, like this excludes Medicaid one, like some of these others, the docs can be in more than one. It's certainly the docs are in one of these regions here. Now, if I wanted to go a little bit deeper on this, and I want to find out, geez, what is the, well, I can pick any one of these. What is the provider region that does the most? Or what is the provider city that does the most in chronic sinusitis? I could do that at this point, right? All I'd have to do is replace the peer definition with the regions. So let's do that. Let's say which region has the most chronic sinusitis? And what I'm going to do here, instead of adding it, I'm going to replace the row axis instead of adding it. And there's your 3-digit zip codes. And I don't know what 537 is, and it doesn't go, no, it doesn't go down. Oh, it's Madison. Okay. So you can see your chronic sinusitis there. If you wanted to do it a slightly different way, you could actually come down here and say, well, how about if I look at it by responsible provider? And we're going to do it by affiliation. Is it 3, Sarah? Affiliation 3 in this?
That's the group level, yeah.
Yep, okay, by the group. I'm going to replace the column axis with the affiliation now. List is likely to get a little larger. Oh, I replaced the wrong thing, my bad. But you get the idea here. Well, actually, no, you don't get the idea. Hold on, I'll go back. There we go. So now you have it by the affiliation level number 3, the group level. And if you were to sort this, you're going to find that Wisconsin does the most, followed by UW Health, followed by Dean Clinic.
So is Wisconsin a roll-up or?
It's a catch-all for non-system affiliated positions.
Okay.
So you can see, just in the first cube here, that there's a lot of different cuts and slices you can do. Anything that you see over here under a dimension can be added to that either as a filter or as a row or as a column. And if you wanted to compare things, you could do that. You could actually take out people who have pharmacy and people who don't have pharmacy. You could look at it by the ER, by the inpatient, by the outpatient, etc. You can look at it by any of these dimensions that are in there. So we just did one, chronic sinusitis. You could do anything you wanted. And for one thing, because of your antipsychotic drug issue there, I'd be interested in taking this and saying, oh, geez, can I figure out which episodes had antipsychotic drugs and then what areas are servicing those? So that's something that's maybe a fishing expedition for somebody that's really interested in figuring out what's going on there. So that's just one. That's provider network assessment. That's episodes. And episodes, remember, are a subset of everything that's going on, and it's cost for those episodes. Yep.
Just a question, so I was just clicking into Dean Clinic just to see the providers that are in there.
Okay.
So if I was, because I'm noticing within there, I'm seeing ENT, primary care, urgent care, different docs, even fill-ins and stuff.
Yep.
If I wanted to just say, I only want to look at, you know, Dean East Clinic, the ENT docs, how would you do that?
Great question. So the question is, as I click into any one of these, I'm seeing all the episodes of chronic sinusitis no matter who treated them, PCPs, ENTs, whatever. The question is, how do I see only those treated by the ENTs? Well, ENTs are part of a peer definition. If I were to take the peer definitions and place them up in a filter in your chronic sinusitis and only selected ENTs, you would get that. So let's do that. So what we're going to do is we're going to take peer definitions, right-click it, and add it to the filter conditions. It's going to show up here. We're going to then go and we're going to filter it, and we're going to select only the ENTs, or the otolaryngologists, I should say. And we'll select all of them, and we'll say OK. And so now the data has been re-sliced so that if you start looking at Dean Clinic, for example, Fish Hatchery, I certainly hope that you recognize these 4 docs as ENT docs. Would that be correct?
Yes.
Yep. Okay. Now, here's the other thing. You guys are all asked all the time by not only WEO, but by Optum, to validate some of this data, right? So if you come in this list and all of a sudden you see an OBGYN listed up here, you want to let somebody know about this because the Wisconsin Medical Society is really giving us the specialties. We want to know what's going on, and we want to get your data as complete and accurate as possible. So as you're doing your analysis, don't let it totally derail you that you see an OB sitting up there, but certainly do say something and bring it to our attention.
So when you went to set the filter
Yep.
for otolaryngology, like I see otolaryngology excludes Medicaid, WEO, otolaryngology, and then another one, WEO, otolaryngology.
Yep.
Do you choose both of them?
Whatever you're looking for, you want to include everything with Medicaid.
So if I chose WEO, otolaryngology, I get everything, including
Yep.
Medicaid.
Absolutely.
Do
The-
not want them, then I would choose.
Right.
Then you would
Yep.
choose without.
Yeah. What that means is it's excluding Medicaid patients or Medicaid episodes from that. Any other questions on how to do this? Because we're going to move to a different slice of the cube. This is only a piece of the pie. I'm going to move to the population view now, which means the episode doesn't have to be attributed to a peer group, doesn't have to be attributed to a doctor. So what we're going to do is go right back to the online analysis, and instead of saying physician episode, I'm going to go physician population morbidity adjusted cost. Now, when we look at the dimensions in here, you can see that the dimensions have changed substantially. We had a much longer list just a minute ago. Now this list is actually pretty short. In this case here, you don't see anything that has to do with ETG in this list. Why? Because these aren't episodes anymore. This is the population. Well, what do you say? Well, I still see peer definitions. Okay, that's a really great thing. What else do I see? I see imputed PCP, so we could do that. I see provider region, provider city. So on any of these measures up here, or dimensions up here, I can select one of the measures that are down below and see what's going on. So let's take a look at, for an entire population, what we might be interested in seeing and what the slices might be. Now, we can either use population cost or population count. That's pretty simple, but we haven't used calculated measures yet. Here we have PMPM. Now that's a great measure to kind of compare populations on. So I'm going to take PMPM, I'm going to add it to the data area. So what's going to happen here is it's going to drop a number in for the entire population, no exclusions, no slices, no dices, nothing filtered, no columns chosen, and it's about $40.74. I find that kind of low.
That's only for Medicaid. Does everyone else just get 0 populated per allowed?
I'm sorry. I was.
So if allowed costs are only in the data for Medicaid,
Yep.
because any other commercial or
0.
Medicare is 0.
Correct.
So
And that's
if you
why
look-
you're seeing $40.74 here, because it's so low, right?
Because it wouldn't be,
It's divided
not
by
a
the
nu-
total population.
and it wouldn't come in as null because it has to be in.
Right. So what we really want to do is we really want to come down here and we want to find the correct PMPM measure here, standard cost PMPM, and replace the data area with that, and we'll get a number that's a lot better, 230. Now, let's say we want to kind of slice this a little bit. We could slice it by any of these here, but a neat slice here is actually the provider region slice. So we throw that in as a row, and we get PMPM by region by your 3-digit zips. And you can see the differences in costs here. This one's pretty low, 546. I don't know where 546 is, but we could look that up. And we have a 255 in here, which looks kind of like the high, and that's 542. So you do have some variation in PMPM by region. Well, the next question I would ask myself is, yeah, well, but let's see what the total costs are. And I could add total standard cost to the data area. And now we're starting to get to some numbers that are actually, okay, the ones that are the lowest, well, you've got quite a bit of dollars there too. So then next thing I might want to add is I might want to add the number of member months. So no filters, no nothing, population. Here's the PMPM, the total cost, and the member months for each of those 3-digit zip code areas. Yes, Raj?
We are not able to get the population mobility adjusted cost. We're getting episode mobility adjusted cost. So.
What?
Yeah.
Network, physician. Oh, yeah. They're missing it, Sarah. It must be pulled out of the roll? No, don't feel stupid. Don't feel stupid. All of the, everything, and here's the question. The question was, I can come down here to provider network assessment, but I can't see population in there. That's what you guys, some of you guys are saying, right? I obviously can see it. Everything that's out here is controlled by your role and your user ID. So it's very possible that the role you're in doesn't give you access to that. Is there a reason for that, you think?
I have.
Oh,
Did you see it?
how many people here can see this? I'm going to pull it out. How many people see that right there? How many people can't see that? About half of them, Sarah.
Yep, I know it's from.
Okay, Sarah's going to fix it. And it's a simple role change, we hope. And then we'll try to redo this again. Was there a reason for it?
It was not a good reason.
Okay, fine. Let's go. That's fine.
It wasn't part of the original,
Roll setup?
role
That's fine.
setup.
Sorry if I stumbled on it by accident, but.
So people probably have to log back up, log out, log
Yep.
back in to get it.
Yep. So folks, if you want to log back out, log back in if you didn't have it, Sarah's going to have it fixed in a flash. Is it fixed? It is fixed. Yeah, so if you log in and log out, you'll be set. And our apologies for not having everybody have access to this. But you should see episode, population, and facility. And then you should be able to get to exactly where I am right here. So we'll wait about 5 minutes till people, did you get it now? Oh, you're just logging in? Okay.
Can you
Yeah.
walk me again through how you did the buy? So when you go here and
Yeah.
back here and then
Yeah.
you start with your definition to the row.
Correct.
And then you ETG.
Yep, and I put it as a filter. Yep. Then I
And then
filtered it.
When you go
Yep.
to filter it, when I go to set my filter, I don't have I just have auto.
No, yes, you do have auto, right? Now click the plus sign next to it.
That's right.
Okay, so now unclick everything and only click chronic sinusitis. There you go.
Okay.
Now do it,
There we
and
go.
poof.
Okay.
Yep, you'll get the right answers now. Yep. Yeah, those little plus signs, if you see a plus or a minus sign next to anything, that means you can expand it or you can bring it smaller. You can contract it. So that's something to keep in mind. So did folks actually try logging in and out and you got it?
You might have to close the whole browser window.
Oh, Sarah's saying close the browser window. You got it? Awesome.
I got back in without having to log in.
And you still have it?
Um,
You have those three things? Let's check.
Oh, no, you don't.
No, you don't.
You're
Right.
on the test thing, though.
Yeah, I'm on the test thing, so.
No, you're not on test. This
Well, I
is
mean,
help.
she's on a training.
Oh, I see. Sarah, she's on the training ID. Is that a different role? Because she still can't see it.
Probably a different role, I'll fix that.
Okay.
Sarah's the greatest.
Okay, so for both episode and for population, we have a cost cube, a utilization cube, and a cost detail cube. And you can see the word morbidity in front of two of these. You can't see the word morbidity in front of one of them. So that should give you a hint that some of them are adjusted and some of them aren't adjusted. The other thing to look for, go ahead, Sarah.
Did you close your window?
I did. I had no log out option, like, so I just closed it out.
The
That's right.
tab or the whole window?
Whole window.
Okay, and you still don't have it?
I haven't gotten in. I'm waiting
Oh.
for you to tell me I can.
You should be able to get in and see it now. Yeah.
Okay, great.
Okay, so last but not least, and we haven't covered this yet, is on any one of these that you decide you really like and you want to save it, you've got that little disk icon up there, and you can just hit it and say Save Report, and it's going to come up with exactly the same screen that you saw Sarah have before. You'll name your report, you'll decide if it's private, group, or public, and then you'll submit it, and then it'll appear in your My Reports, so you'll never have to create that same report again. Okay, now let's take a look at, in this case here, the difference between physician episode and physician population, not morbidity adjusted, but at the cost detail level. So I'm going to go into physician episode, I'm going to click on cost detail, and when we expand the cubes, again, everything that's in the dimensions and measures is pertinent to the cube that we're in. And you can see in this case here, we've got a lot of dimensions that we can consider here, including some of your custom dimensions up here. You've got custom contract type, custom member exclude code. And Sarah is going to help me explain the Brookings member region. I forget what the answer was on Tuesday, but Brookings meant something.
It predates me joining WEO, but as far as I know, it was a specific research project between WEO and Brookings Institute, and they used the Dartmouth Atlas region definitions. So you'll see member region Brookings and provider region Brookings, and those are the Dartmouth Atlas regional definitions. I don't know
Okay.
why they're labeled Brookings and not Dartmouth. I didn't do that, so don't ask me.
So, and then you have, provider and provider region bookings. You have an employer cut at episode end quarter. You've got your ETGs, your exclude code, your genders, number of episodes. Now, why is this important, number of episodes over 10, 20, 30, and 40? If you're comparing physicians, well, 10 episodes isn't very much, right? So I'd be definitely going for over 30 in this particular case. Outlier episode status. Here's the difference, a big difference, between the cubes in this area and the quick lists. If we start counting the total number of episodes up here, may include outliers. So let's try to see the difference there. What I'm going to do is I'm going to simply get all of my ETGs by MPC, and I'm going to put a count in there, and then I'm going to put a filter on for outlier status.
Oh, I don't see that either.
Uh-oh.
The number of episodes over 10, over 20.
Oh, potentially you're in the wrong cube. Let's find out. Let's see, cost detail. Okay, you're in population cost detail. You should be in episode cost detail. That's it. Yep, that's why you don't see it.
Thank you.
Now you see it. After a while, you'll get used to which cubes do what, but right now it's kind of like you're kind of fishing. Oh, where do I go for this? Once you start using it, you'll know where all this stuff is. So what we're going to do is we're going to look at our episodes by outlier. So I'm going to take my ETG, and I'm going to add that to a row axis. And of course, that's going to put all my ETGs right in here. I'm going to go down, and I'm going to get a measure called episode count. And I'm going to throw that as the data. So now these are all of my episodes in each of these areas. Now, I'm going to go down and take that outlier episode status, add it to a column axis, which is going to show up across the top. Tick, 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 tick. There we go. And here, you're going to be able to see all of your episodes. You're going to see the low outliers, the high outliers, and not outlier episodes for each one of those.
And that was based on outlier episode status?
Correct. Correct.
And you added that as a filter?
I add that as a column.
A column.
Yep.
Could you show that one more time?
Show the what?
How you got there one more time?
How I got there? Sure. So how I got there to do this is I went to, let's see this one called outlier episode status? I right-clicked it, and I said add it as a column. That's all I did. And then I got rid of this to show this. So now you can see that when we do analysis for physician network assessment that's adjusted for morbidity, when we use the tool, the Bucky-Badger report, right? These high outliers, there's 316,000 episodes that get truncated because they're high outliers. There are 284,000 episodes that get dropped completely. And the ones we use are these 8.4 million episodes plus the high outliers that are truncated. So you get about 8.7 million episodes that get used for analysis, which is a ton. That's more than enough. If you're going to do any analysis in these cubes, you have to pay attention to, whether or not the cube gives you the opportunity to say outliers or not, or complete episodes or not. If you're not paying attention, you're likely to get an answer that disagrees with your Bucky-Badger report, that disagrees with your quick lists, and you're going to sit there and say, why? If you're using the data mart, it's even worse, right? There's no even clues that you're doing it. You have to just know the data and know the data mart. So if you're getting the data mart, I highly encourage you to talk to Sarah, talk to somebody that really knows what the data mart is, so when you do your analysis, you know enough what to exclude. For example, member exclusions. Sarah's got a bunch of peer groups that are excluding Medicaid members. Well, if you didn't know that, it's not going to tell you that on the inside of the data mart. It's just going to be data tables. You can grab all the episodes and you're going to say, wow, I've got them all. How come I have 6,000 more episodes than it says on the front end? Well, you excluded all those members in that peer group.
So with the high outliers and low outliers, if you were doing your own report here, how
Yep.
would you exclude them?
How would I? Oh, absolutely great question. How would I exclude them if I just didn't want to see them? What I would do is I would take, and instead of making them into a column, I would take that column, high episode outliers, and I would actually set a filter on that particular column. Or I could actually remove this completely. I could go back here and I could take the same episode status and I could either drag it or right click it up to filter, set my filter, come down here and say I only want to see is not an outlier. Now, keep in mind, is not an outlier is not the only thing used in PNA. It's is not an outlier plus truncated episodes, right? So there's a difference. So in this case here, we're saying is not an outlier. I'm going to say OK, and all of those episodes are going to reflect the 8.4 million that we had before. So now, when I come down here, and I say, OK, I want to get total episode costs here, total standard cost, add it to the data area. Now this only reflects episodes that are not outliers right in here.
And then you also mentioned about the completed episodes.
Yep.
So how would you see if you only had completed episodes?
Okay, here's complete episode status right up here. So let's say, for example, I wanted to make this into a column axis. I could do that, and what it's going to do is it's going to move around, and it's going to show you all the different kinds of, all the different kinds. And here we go. So you've got your complete episodes in these two columns right here, and these are not complete episodes in these two columns right here. And because we're losing only the not outlier status, really what we're really interested in is it's not an outlier and it's a complete episode. That's what we're looking for.
Okay, but if I want the numbers to match up closely to what I would get on the list, wouldn't I exclude the is a low outlier but include the high outlier because these are going to only be truncated?
That is
Or-
correct. If you
okay.
want the number to match, the dollars won't match because it's going to have the full episode dollars not truncated.
Not truncated.
Right. And that's because we're in cost detail, remember. Cost detail means everything, right? If you're in a morbidity adjusted fashion, it's going to take into account those factors. You know, and don't get too overwhelmed. There's a ton of stuff in this. If you're not using it, too late. Well, there's a ton of stuff, and if you don't use it a lot, it's like, oh, where do I go next? And am I doing the right job? And where is it? You've got a lot of people to draw on in terms of talent. The whole WEO organization absolutely knows what they're doing. We've got our organization. There's an opportunity to go to the Impact Users Forum and get a lot more information there. So take advantage of all the information that's out there. But don't hesitate. Don't spend 3 days looking over literature for one answer. Call up Sarah, send her an email. Call me, send me an email. We'll give you the answer in 30 seconds or less if we know it. And it's a lot faster than going through the literature for 4 days, right? And you will learn eventually. It just takes time. There is a lot to it. Any other questions on this or this kind of a slice and dice in the cubes? Any other slice and dice folks want to see?
Can you do readmission stuff through this?
We can actually look at that next. That's a great question. So one of the things under provider network assessment, we already looked at episode. We looked at population a little bit. We didn't look at facilities yet. So that's where we're going to go. We'll go into facility. And it's morbidity adjusted length of stay and admissions. Your question was readmissions. Well, that's the only place in here that I saw the word facility. And facilities and readmissions kind of go together, right? So the first thing you're going to look for is say, do I have the ability in this cube to see things like readmissions? Is it available? So I'm going to open up first all of my dimensions. Then I'm going to go down to my measures. I'm going to look at my inpatient admission measures. I'm going to open up my calculated measures. And I'm going to say, okay, oh, look, I do have readmission information. Right? So now let's use that. Let's go up, and we have this thing called inpatient facility here. My suspicion is that it's going to give you the name of an inpatient facility, and hopefully no physician names. Let's see, should I do provider or should I do a fill? Which one do you recommend, Sarah?
It doesn't matter because it's the bottom level.
Oh, so this
It's
the
the
bottom level in either of these?
Yeah.
So it's going to be
So-
this one right here?
Yeah, so
All right.
affiliation is not applied to hospitals and facilities. We're working on that, and that needs to come from the hospital association. So the medical society provides us with physician affiliations.
Mhm.
And we don't have a hierarchy applied to facilities. So they're all gonna appear under Wisconsin as the affiliation.
Okay. So here's a trick right off the bat. If I just say put my providers in here as a row, what am I going to get? every provider yeah, right, even that they don't have any admits. What I tend to do in these cubes to make it a little quicker is I tend to come down here and I tend to actually put in what I'm looking for first. So maybe what I want to do is put in inpatient admits in the data area, and then I'm going to put in readmits for 30 days into the data area. So that's going to give us the overall kind of thing. Now what I'm going to do is add in that provider name as a row, and it's only going to populate those places that have had admits or have had readmits. And if you wanted to sort this list, and we'll show you a trick in a second, I could sort this list, and I could find out the one that has the highest readmits in 30 days. In this case here, it's Aurora, about 15% it looks like. Now, Sarah's got a neat little trick here, and I just learned it the other day. If you actually want to get a percentage out of these things, you can actually create your own measure, or as Sarah noted, you can kind of go here and say, which one was it? Rank, auto percentage, that's what it was. Auto percentage, percent of column total. Tick, 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 and then we'll sort it by that and see which one has the real highest percentage. Yeah, there we go. Actually, it looks like that one is it anyway. Yeah, the rest are teensy, teensy. Oh, well, that might not, yeah, that's teensy. But we'll sort it by that anyway.
Well, how did you get the percentage?
How did I get the percentage? I actually clicked on the chevron next to readmits, and it gives you a big drop-down menu. And then in that drop-down menu, you have a bunch of things you can do. One of them is this auto percentage, and you can actually say percent of column total. So what it's going to do is it's going to take the column total here, and it's going to give a percent of it. So these guys have 8% of all the readmits. Well, they also have a heck of a lot of admits, so that's probably correct. But what I really want is I want the differential here. I want 1520 divided by 11,125. Yep, yep. So I can either go and pick it. No, actually it's an index.
Isn't there a rate
Is there?
under inpatient admissions readmits 30 days?
That's what I have up there. It's not the rate,
Oh,
though.
that's the number.
Right, that's the number. So I wanted to show them how to do a calculated measure anyway. So one of the things you can do here is if you don't see it in one of the dimensions or one of the measures, and you want to create it on the fly, what you can do is you can actually go ahead and you can actually click the chevron down, and you can do something called add a measure. Then you can add a formula. And what it does is it gives you the ability to build formulas down here. So I'm going to call this PCT readmits. It's going to say the same thing there. So I'm going to take my readmits in 30 days, and I'm going to divide them by my total inpatient admits. Now you can see I can do standards, I can do measures, and I can make it 3 ways. But I'm going to just change the format now to be a percentage, and we're going to have, let's say, 3 decimal places. Say OK to that. So you've just created a measure.
Well, how did you get there? Custom,
Okay, let me show you that. How I got, well, it's gonna take a second till it does something here. Did I like not do something right? Oh, here we go. No, that's right. Why isn't that working? All right, how did I get there? You see, you got the down chevrons? Why didn't that work? Oh, that's where it was barking at.
Wasn't it
I
the
did.
requirements, 30 days divided by?
This is it right here. I wonder if it's the browser. Because it should just, I mean, it's not barking at anything, really. I mean, it says may not return, but I'm not using a member property. I'm going to try something different.
It's just the,
I'm doing it from right here. You do it from this one? Oh, I've never done that. Okay, let's find out. Add a formula, yeah. Should bring up the same thing. Yep. No, it's not working from there either. I think we've got a browser issue. What should be happening at this point is I put that formula in there, it should pop it right in there. And the browser doesn't appear to be kind of grabbing it and moving it on. I probably don't have compatibility mode set, now that I'm thinking about it.
So, this is the
Mine works.
Yours worked? You have compatibility mode set up then.
it's like average on
You didn't change it?
though, it takes a
Uh-oh,
while.
mine didn't work.
That's good.
Where the heck is compatibility mode on this?
But here's the thing, so
History, Google.
for this readmin percentage, its average is 8.14%.
Did anybody else's work when you actually did that? Or does it just hang right here? Yours worked?
yeah.
Oh, so some of them are working. It's got to be compatibility mode.
I feel like if this is 6%,
Yeah, that's perfect. Yeah. Okay, so if in your browser you haven't set compatibility mode, it looks like that's what's going on. So it should actually put another percentage in there next to it. Yep.
That last column, we admit 30%.
Yep.
Basically, it seems like it's a pie chart.
Yeah, no, this is, all that is the total of this divided by that. That is not this divided by this, which is what I want. I want this divided by this.
We got it.
You got, yeah, so you guys have compatibility mode set. I don't have it set. That's the only difference. So does this give folks what they wanted when they said they wanted facility readmits? Is this something that's useful? Yeah? Okay. Absolutely. Absolutely. So in order to set up the formula, you can either go to this chevron here and you can say add a measure. You can add a formula. Oh, she's helping her. Okay. That's even better. Okay, yeah. So what I would do is add a formula. Once I've got this formula custom measure thing built down here on the bottom, what you do is you simply give it a name, like say PCT3. You don't have to give it a display name, it'll give it the same thing. Then you come down here and you say, okay, what do I want to do? Well, what I want to do here is I want to take my readmits in 30 days and I want to divide them by my total inpatient admits. And then all I'm going to do is say okay at that point. And if I had compatibility mode set, which most folks do, what happens is it pops up and puts it right down in this column right here. And a lot of folks got that because they have that set on the computer. That's all it is as far as I can tell. Oh, wait, there it goes. Oh, maybe everybody's just way slow. That's maybe what it was. I was impatient. I'm sorry, folks. I was just impatient. There we go. Okay, so what we've got now is we do have that percentage sitting off to the side. And if I wanted to then take that and I wanted to sort that descending, I could do that as well. Oh, look, I have every one of them, too. I just didn't wait long enough. Impatient. let's take a look.
I'm getting all zeros.
Right, and now that would be probably because it's in a percent and you don't have any decimal points after it. So if you
Okay.
click on the chevron down
Okay.
and go to that particular measure, set format of the measure, down, down, down. Yep, yep. Go to, what's the format look like? It says, it doesn't even say show percent and the decimals are 0. So go ahead and show percent and set the decimals to like 3.
Okay.
Yep, now say okay.
That's okay.
Yeah. Bingo.
Oh, there we go.
Yep.
Got it. Thank you.
Everybody else get it? Okay. Anything else in the facility world that folks are interested in looking at the moment? The facility one is just one single cube, and you can do a number of things with it. You just got to be careful how you attack it. And by that I mean, don't ever have it put out every provider's name first. Select the measure you're looking for, or else it'll be a lengthy process.
Well, is there a way to say, for example, I only want those facilities which have at least 30 admissions?
Mm-hmm.
Can I set that filter here?
Okay, let's take a look at, filter is exactly the right word, right? So now, let's go up. No, filter is exactly the right word. If we go back to here, right, one of my calculated measures are allowed per admission. I've got cost per day. Well, the trick is, I can't take, and I'll show you, if I were to try to take this inpatient admits here and right-click it, there's only one thing I can do with this at this point, right? I can't make it into a filter because it's actually a measure. However, if I go to inpatient admits here and I click down, we have a number of different things that we can do right in here, right? Including sort ascending, sort descending, define the sorting rule. We could actually look at this and say rank order it. We could do omittable, add an alert, add a measure, edit a measure, do the 80-20 rule. So that's what you've got available when you work with the measures themselves. You don't have the ability to actually filter that particular measure. But if you were to sort it descending, you would effectively get what you were looking for. So there it is at the top, and then you just work your way down until you find, you know, your 30 that you're looking for, which is like right down in here.
Yeah, I got it. Thank you.
Yep. Other questions?
Would you be able to say, I only want those readmissions that were readmissions from nursing home patients?
Great question. The question is, I only want those readmissions that are readmissions from nursing home patients. Answer, no. Very, very bluntly, answer is no. The reason for that is this is the classic CMS readmission criteria. Any cause, any facility within 30, 60, 90 days kind of thing. Now, Optum does have available an access spreadsheet that works off the data mart that does everything you can ever think of for readmissions. It does same DRG, same facility, different facility, from a SNF to a not SNF. But it totally does not work on the front end. It's a total back end data mart kind of thing. And that's some of the power of the data mart. Because in the data mart, you can get anything you want. Sarah could do this because she has the data mart. But we can't do it in the front end. I can give you that.
If you give her the magic table, we have the data mart, can we do it too?
You could if WEO, I mean, I have to do stuff through WEO because WEO is my client, right? I certainly could. And as long as Sarah approves it, I don't care. Doesn't matter to me, right? So.
I'm not there yet, but I guess.
Other questions on facility? Because if we look, not because, but when we look, facility, right here, there's only one thing to do, length of stay and admissions. It's a very simple cube. If you look at either of these other cubes, you really have 3 different things you can look at. Cost, utilization, and cost detail for both episodes as well as total population. Okay, let's skip cost and use just for a second. We're going to come back to it. And I'm going to go down to population and care management because we haven't even touched any of the disease categories or the care categories. So what I'm going to do is I'm going to go into population and care management, and the first thing I'm going to do is look at health risk. We talked a lot about risk before lunch, and what we're going to do here is we're going to segregate our risks. First thing I'm going to do is go into measures, and I'm going to look at my measures, and I'm going to pick the prospective risk and add it to the data area, the retrospective risk and add it to the data area. and I was off by just a little bit this morning. I said 1.41. You guys are at 1.49 and 1.45. Retrospective risk for your entire population, nothing excluded. Everything's in that number, right? Now let's start breaking it out. Where is the real risk? I can go back up here to my dimensions, and I can cut the risk by any one of these things up here. So one of the things you might want to cut the risk by is this member region. You know, what's your risk by region? So if I open this up a little bit, and I drop it into a column, oh, I didn't mean column, my bad. I meant row, yeah. There we go. Starts member zips. Actually, we'll keep it at, there's a better way to do this. Sarah, which one under the customs was not zip?
You doing it by provider zip or member zip?
I was just doing the member
one?
zip. This one?
Yeah.
So I'm going to replace the column axis. I wanted it to say like the regions.
Replace the row, you mean?
Yes, that's exactly what I mean. All right. Replace the row. What a dummy. No, that's still giving me zip codes. Wasn't there one that gave me like the counties?
It's giving me the region.
Yeah, that's the one I thought too.
First,
Are you replacing the row?
Yeah, I did.
the one that's not grouped.
The one that's not grouped?
Yeah.
She's the first one on the list.
Right here.
No, the next
No,
one.
the next.
Oh, the next, this one?
Yeah.
Oh, okay. Replace the row axis. Yeah, that's kind of what I wanted right there.
Can you widen that so we can see where you...
Whoops. What, make this
Yeah.
disappear like this?
No.
Oh, make it reappear?
Because I can't read the very far
Scroll
left
to the left.
column.
Oh,
so
okay.
you can see where it is. Okay.
So it was under custom member.
Right, and it's the first one that says custom member region Brookings. And now what you can see is you've got retrospective risk and prospective risk, but one of the things is you've got some out of state, you've got some unspecified. It might be nice to know, let's see, who the membership is in those particular areas. Or at least how many members you've got in those areas. So here we go, and we can see that predominantly it's northeastern, southeastern, and those are your things, your risks. So now if we open this up, we can actually get it by county, and you can see the risk by county. Now, a lot of the time when you're looking at risk, you're going to look at the risk and you're going to say, you know, let's take Green Lake, for example, versus the one right underneath it, Kewanee. That's a pretty substantial difference in risk right there. And so you have to ask yourself, what's driving that risk at this point? So that's where you'd look into each one of those counties and you say, okay, what's the biggest driver of the risk? And that's where we're going to go next. We're going to go into what kind of diseases do these particular counties have. And you can look at some of these others, and there's not a heck of a lot of difference in here. But whenever you see large differences in the risk with high enough populations, there's something different going on in that particular county. What is it? I don't know. Something to look into, though. So that's the risk cube, and you can either use prospective or retrospective risk. Now, if I want to look into it a little more deeply, I can look at it on the disease prevalence. What's prevalent in terms of disease? So if I click that, you're going to see over 40 different diseases represented here. Anything from allergic rhinitis to asthma to bone and breast to prostate cancer, CHF, etc. So if you wanted to find out, for example, how many of your members had CHF, you'd simply click CHF, you'd add it to a row axis, then you'd come down, and then you'd want to add in from there, you'd want to add in a count. So we'd go to measures again. And here's your disease prevalence members. And I'm going to load the number of members in there and add that to the data area. And what you've got is CHF. You've got 7 million, and I hope I get a question out of this, members that don't have CHF and 46,000 that do have CHF. What's the question I should be getting out of this? I got it on Tuesday's class, and you have to keep quiet because you were in Tuesday's class. You have to keep quiet. You were in Tuesday's class. You know the answer.
I'm sorry, I wasn't.
You wasn't paying attention. Even better. Even better. So.
I don't even remember Tuesday.
Oh.
That's more people than Wisconsin has.
Bingo! That's it. You hit it. That's more people than Wisconsin has. Bingo! You got it. That's 2 years worth of data. So the next thing you're going to do is go in here and say, okay, I only want the current year data or the current membership. So what I can do is I can go back into my list of dimensions and say, okay, well, how can I determine? See this active last month flag here? I can actually take that and drop it as a filter condition. I can actually filter on it. And I can say I only want those that are active. Now the question is, wow, isn't 6 million still too many? So now we're going to go down and we're going to say, okay, well, what else can we do here to make this like a year over year or a onesie twosie? Oh, wait, time period. So let's take time period and add that to a column axis. So now what we've got is we've got about 2.9 or 3.1, which is about the right number that you have in the data set at this point. You've got about 18 to 20,000 that actually have CHF. Now, a really astute person in class last Tuesday said, well, I want to know who's got CHF, but they also have something else, right? So these comorbid conditions, you can do that from here as well.
Before you go there, how
Yep.
did you get to the disease again? Where was that?
Absolutely. I went down here to online analysis, population care, and disease management. Disease management. Oh, right. Disease management. If I could run a mouse, we'd be good. Disease prevalence.
Got it. Thank you.
So now, let's say I want to find everybody with CHF that also happens to have diabetes. I'm going to add diabetes to a row axis. So I've got CHF as a row axis. I've also got diabetes as a row axis. So now I've got a set of columns that basically says CHF, no, and yes. Well, the yes under CHF, if I expand it, expands out to the diabetes column. So yes, I have CHF. Yes, I have diabetes. There's about 7,500 to 7,900 members with both of those conditions. If you want to know if they have an additional condition onto that, all you have to do is come back and say, well, do they also have depression? I'll take that and I'll add that to a row axis.
Paul,
Yep.
is there a way to say, tell me what all of the conditions these people have, or do you have to go condition by condition?
I can actually tell you all of the conditions in one fell swoop, but not by person, because in the WEO data space, you can't do it by person.
Right.
So if I want to do everything, let me finish this and then I'll get that. No, don't be sorry. That's good. So now we've got CHF, diabetes, and depression. Yes, yes, and yes. And you can actually see where the numbers are starting to fall. They're actually getting a lot of comorbid conditions once they have CHF and diabetes. So now getting back to your question, can I see all of the conditions everywhere, right? There is another category down here called disease-related. If I were to click disease-related down here, and I were to simply replace the row, if I do this right, there we go. And now I have to go back and start replacing the actual dollars and the values here. So I'm going to remove the dimensions here. And I'm going to remove the dimensions here. Okay, now I have all the diseases here. The next thing I want to do is go down here. Whoops. And I want to say, okay, well, what are my costs in each of these particular areas? And I'm going to use standard cost. And this is a great area to talk a little bit about what happens when you have disease costs, because there is some overlap. So here's all the disease costs, and there is some overlap in here. The reason there's overlap in here, so the same number, the same claim could be here and here and here, The reason there's overlap there is because sometimes it's ambiguous as to what the drug is being used for. So if a patient happens to have a benign neoplasm of the GI, a benign neoplasm of the gut, or a benign neoplasm of the liver, and you're giving a specific chemotherapy, you could apply to all three. Don't know which one, so it goes into all three buckets. So if you totaled up this, it's going to total up to way more than what you have. So the idea here is we're trying to get close, but we don't know always exactly what's happening. So if somebody goes in for those three conditions and they go in for an office visit, well, which one does it apply to? So in diseases, we don't kind of fine tune this. We just say it could be any one of them, so we throw it in each category. And we don't divvy it up either. It's thrown into each category.
Is it possible, we were looking at CHF.
Mm-hmm.
Is it possible to say within those that have CHF, what other conditions do they have? Because you did that with CHF and
Yep.
one condition.
Right.
Can we say, give me a distribution of how many people with CHF have 0, 1, 2, 3, and comorbidities?
The answer to that is in this application, no.
Okay.
You can do it through the data mart, though, because that exists. Within iPro, you can do that. And it's a different slant. See, what you're asking is you're asking a member-focused question. This is not a member-focused application. This is a population-focused application, so it's kind of different. Yep, no problem. So what else can you do in here? Well, you can see you can actually slice this in a lot of different ways. You can slice it by product. So if you wanted to see disease-related costs by product, and we were to take that and add that to a column access, you're going to get this total standard cost dropped out by product. So if you want to do Medicaid, Medicare, and commercial, there we go. In this case here, you've got it set up for commercial, federal employees, Medicaid, and Medicare. And you can see the dollars are kind of spinning out to each one of those categories. So if you were really interested in Medicaid and you wanted to find out what the highest cost one was, you'd sort the Medicaid column. Other means anything that is not in this list. So that's all other diseases. But in this case here, it looks like mental health in the Medicaid space is the biggest user or the biggest disease category. If we wanted to check on the commercial side what was there, we could sort that, and we'd get, hopefully, back, spine, and pain. Yeah, that's pretty typical. Yeah, so it's a little different. And you don't even get down to the mental health stuff until like number 10 or number 11. So there is a significant difference in the population.
How is mental health different than depression as an example?
Depression is very specific, and it's a subset of mental health. It's very specific.
Mental health has 186 million and depression has 348 million, so what am I missing? Now, the subset would be
Depression has 348, right? So people have been basically diagnosed with depression.
And mental
but-
health seems to have 186.
Yeah,
Is it a subset or not a subset? They're exclusive, right?
they're exclusive, yeah.
Yeah.
Oh, I'm sorry, I said the word subset.
Oh,
No, totally bad. What happens is, when we look at this, we don't look at it by episode. Because remember, when you looked at ETGs, it was mental health, and then underneath mental health, you had substance abuse, you had depression, you had all the other conditions. This is looked at it by a specific disease. So we look at the actual clinical diagnoses, and it goes into there. So there's a clinical diagnosis for depression, that feeds that one. There's a separate clinical diagnosis for wherever the other one is, mental health, and that's what feeds into there.
Okay, so it will be based on very specific
Yes.
diagnosis codes.
Yep, has nothing to do with ETGs.
Got it.
Yep. Different look at the data.
Right.
And that's a great intro to why you'd use this versus using episode treatment groups or episodes. This casts a fairly broad net. So if you wanted to find everybody that's got one of these conditions, this is a great way of casting a broad net and finding the total dollars. So let's say, for example, we take breast cancer here, $196 million is what we're spending commercially. If I looked at my episodes, do you think those would total to $196 million? Much, 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 much less, right? Because episodes are very specific.
Completeness.
Yep,
all that stuff.
yep. So this is a wicked broad net compared to episodes, which is a fairly narrow net. People use this in different ways. One of the ways folks could use this, if you guys had access to member data in here, one of the ways you could use this is to identify everybody who is a diabetic with a very broad net. But if you want to be very, very specific and be 100% certain somebody's a diabetic, you would use episodes. Because, for example, diabetes can be gestational, correct? Well, guess what? It fits here because there's a diagnosis of it, right? However, in an episode, that's not going to fit into an episode. So you're not going to get an episode of diabetes severity 1, 2, 3, or 4. That's gestational. So that's just one tiny example, but there's a lot of other examples where it's much more specific. And here, you don't have to have the preponderance of the evidence that it is in fact that condition. It's just, hey, we saw a diagnosis code for it. Boom, it's in the list. Otherwise, in an episode, you need the physician visit, you need some other stuff around it to make sure that that's what it is. Questions? Yes, sir.
Is there any way within the interface itself to see, okay, other is...
Others, everything else but.
To see, well, is that it would be going to look in the documentation, see what is...
What other is?
Yeah.
No, other is, if it's not in one of these categories, it falls into the other category. Right, everything else falls into there. Now, if you want to find out specifically what claim lines fell into there, you'd have to go to the data mart for that, because that's at the level that we're at. Okay. Okay, so now we can look at this in a number of different ways. Time period, type of service to level 2. It's always interesting to look at things, how people are using services. So what I'm going to do is I'm going to take type of service level 2 and I'm going to replace the column axis. One across the top. And what we're going to do is we're going to see all of those disease costs split into the various areas and where the costs really are going. So in this case here, for each of these disease areas, what we're doing is we're splitting them into ancillary, inpatient, outpatient, pharmacy, and professional services. So now, if you were really looking at focusing on something, let's say you're focusing on pharmacy, and you want to find out what in pharmacy is really driving your costs, you could simply click on that. Now we have two levels here. If we look at pharmacy, this is the highest level, but if we scale down one, we can get slightly more detailed. So under pharmacy, if I click on the plus sign, we have those types of agents which we saw before. Let me just scroll over. And there's a bunch of them. But you can see cardiovascular, blood formation, central nervous system, etc. So you can break it out that way. Now, in this particular case, you might be interested in only one of those disease conditions, in which case I'd throw it up as a filter, and I'd take these things and rip them around to be the rows instead of the columns. But that's really, you guys have to choose what you like to look at. And once again, taking any of this stuff here and hitting the save, saves the report just as it is. Hitting the Excel will save this one sheet, or going up to this down chevron and hitting it and going down save to Excel can save the entire data set that you're working with. So a lot of different ways of saving it, a lot of different ways of sticking it out there. You can make a graph of this. We've already seen how we can make graphs. This would be a really messy graph because there's so much stuff out here, but you could do that as well. And that's population care management in the disease category. Okay. Okay, let's take a look at cost and use now. There's a number of different areas in cost and use. Cost and use here contains everything. All the claims are in here, all cost and use information. But we can look at it from a population perspective, an episode perspective, an admission perspective, a pharmacy perspective from both episode and population, a radiology perspective from both episode and population. Now, we've touched a lot of them, so I'm going to start with the bottom up, and I'm going to look at radiology population. And what we're going to want to do here is we're going to want to try to figure out, is there a difference in MRI rates between various communities in Wisconsin? So what I'm going to do is I'm going to work my way through this list, and I'm going to say, okay, first I need to know, do I have a dimension here that is going to allow me to do counties? And as I look through the list here, I do have this member region here, and I also have the provider region here. We can use either one of those. So let's take the provider region here, and it's the first one I was told the last time, and add it to a row axis. We'll see if it is. Yep, that's it. So here's all the northern Wisconsin stuff. Then let's see if there's a difference in the number of times a radiology encounter happens. So I'll take encounters per 1,000 and I'll add that to the data area. Should appear here shortly. There we go. Now I'm going to simply work with this. I've got what I need. Now if we look at this, 192 per 1,000 versus 80 per 1,000. Seems to me to be a big difference there. So now what we want to do is kind of drill into that and say, okay, is there something in this area here? Is there one county in this area here that's really driving that, or is it everybody? So all we're going to do is continue to hit the plus signs until we get down to that point where we know what's going on. So I'll take northern Wisconsin and I'll drill into it. And as you can see, we've got Brown heading the list here at 56, far and above, double anything else that's sitting out there, right? Except for Winnebago. So I don't know Wisconsin. Is Brown and Winnebago close to each other? Ah, they are. So there might be something about that area that's different than every other area. So to you guys, you would know this. Is there a big radiology facility out there?
Brown County is Green Bay area.
Ah, Brown County is Green Bay. So they have many facilities. Yeah. Okay. And look, all the rest of them are fairly low. So let's go to the other one that was low, which is the western one here. Open that up and see if we see anything similar. Here we go. And you can see Eau Claire is high, as is La Crosse, but everybody else is low.
And those would be the more metropolitan areas.
Metropolitan areas, yep. So you might want to just consider that and say, okay, well, are there certain conditions driving that? And remember we had here cost and use, and we had radiology per episode here for radiology? We can now start to say, let's pick one of these communities. Let's pick, which one was the highest here? Here we go. We'll pick Brown County, and we'll look at episodic use of radiology within Brown County to see if there's one type of episode that drives it. So I'm going to come to cost and use. Under online analysis, I'm going to come to radiology episodes, and we're going to pick Brown County if we can. And I say if we can because we look into the cubes first to see if we have those dimensions. And we do. We've got that provider region there. We've also got ETGs here. So what I'm going to do is I'm going to put ETGs on the row axis, showing up here. I'm then going to take the custom provider region here for Brookings, the first one, and I'm going to stick that up in a filter condition and pick just Brown. Set my filter. Get rid of that. There's Brown. And since I'm in the radiology cube, I can take a measure and do a calculated measure, encounters per 1,000, add it to the data. I can almost guess it's going to be orthopedics, but we will see. Oh, I was so wrong. Obstetrics. Probably. Pregnancy with delivery is the high one. That's really interesting. I filtered on Brown County, radiology, and Brown had the highest utilization, and that's what's driving it, the obstetrics. All the other ones were really low. That's really interesting.
Why does it say 158 in the total, but
Right here? Because what it's doing is it's doing a rate per 1,000, right? And it's not simply an addition of these. This is 15 per 1,000, 61, 71, et cetera, per 1,000. So this is the average over the entire obstetrics community. And you can see this, it does the same thing for, or should do the same thing for all of these. Oh, that's a big one. But yeah. Yep. So we've identified that in Brown County, it looks like it's the ultrasounds that are pushing it all. And this is rates per thousand, remember. So if you look at all those other counties out there, these guys were twice as much as everybody else. Why are there that many more ultrasounds in Brown as everywhere else? That's a question to ask. Yes, sir.
If we have a moment, I'd like to confirm an analysis of prevalence of disease condition.
Absolutely, let's do it. Let's do it.
We're trying to look at asthma, and we've looked at it before, and it's very likely that I made a mistake somewhere. I just pulled out, basically, just looked at asthma prevalence
Yep.
across the state of Wisconsin.
Okay.
We know that the national average for asthma is about 8.5%. Wisconsin is about 9.5%.
Half.
9.5%.
Yeah, but half of 18 and a half, right? Oh.
8.5%.
Oh, 8.5. Oh, okay, okay.
9.5%. So that's where the number is. And
Yep.
from we are seeing 2%. So I'm missing something.
Hmm.
It's a huge gap. If it was 7.5, 8, I could understand.
Yep.
2 versus 9.5.
So prevalence. So did you look in the disease prevalence specifically for
Yeah.
asthma? Let's walk this through. Let's walk this through.
Very likely I made a mistake.
Yep.
but I just wanna-
Let's walk it through. So we're basically going to go to population and we're going to go to disease.
Yep.
It's disease. Whoops. It's disease management, and we're going to go into disease prevalence.
Right.
So the first thing I'm going to do is I want to actually set this up so I only get 3 million patients instead of 7 million patients, because you don't have 7 million here. So the first thing I'm going to do is go down, and I'm going to find my time period, and I'm going to take that time period, and I'm probably going to stick it in as a filter condition. And then I'm going to filter out just for the current period. Takes care of that part of it. And the next thing I'm going to do is look for asthma. Right here. I'm going to stick it in a row axis. And the last thing I'm going to do is come down here to a measure. Members. Number. Add. Is that what you got, Raj?
I have 65, 696 in yeses.
Yeah, it's pretty close.
Enough,
Yeah, it's close enough.
And about 3.3 million, which is
Yeah, okay, so differentially, yep.
total.
So that's exactly what I'm getting as well for asthma.
So we're getting 2%.
So let's talk a
Because if I
little,
divide
Yeah.
431 by 3.5 million,
Mhm.
that's about 2%.
Mm-hmm.
so we don't have Medicare fee-for-service.
Yep.
Okay, but that wouldn't account for that large. of a
And we don't have uninsured. And so the thing that I would wanna know is, how is that asthma disease, defined in the processing?
So, good point, Sarah, but if you look at 3.5 million, that's still a very large chunk of the Wisconsin population.
Right, so,
So for this number to be this low, and for us, if we assume that the average would jump up to 8.5 if we added all the things we are missing, we're probably saying everybody who doesn't have insurance or is in Medicaid, almost everybody has asthma.
Mm-hmm.
For
so,
the weighted average to work out that way.
Well,
That's what I'm
what I-
confused
Yeah, I know where you're
One-
going with this,
One
yeah.
of the things that I think might be lurking here is pharmacy.
Yep.
And the ability to identify people with asthma specifically based only on their medication, inhaler. We don't have pharmacy data on all 3.5 million.
That's a good point.
Do you have, is there the exclude dimension?
I believe there is.
Because the.
Yep, I have the exclude code. Is that I don't know if that's the one you're referring to.
So, not every patient in WEO do we have their pharmacy claims. And my guess is that for an asthmatic who's in control, you're really only gonna see pharmacy claims. And for a patient that we don't have those pharmacy claims, they will never test positive in WEO for having asthma.
Do you have Medicaid pharmacy data?
Yes.
Right? So if we can look at the Medicaid number, it's getting closer, that would help.
Yep,
We're just trying to understand. what we're
definitely,
missing.
definitely.
Okay, so we put the exclude code in, exclude partial claims, include, so this is the full claims load right here.
You gotta expand that one more, Paul, because there is,
Under here?
under the full claims, because
Yep.
there is with RX and without RX in those numbers.
Okay, no, there's include commercial, include Medicaid under that.
Okay, so there must be.
That must be the other
a
exclude
different
code.
custom field,
Yep.
yeah.
Let's go back and look. Custom member exclude code, that's
Yep.
probably it.
Yep.
Replace the column X's. Here it is, full coverage and have RX benefits. So then we'll just open that one up.
Yep.
Full coverage and have RX and no RX. So this is the have RX.
Okay, so we should be looking at 17,941 divided by
522088. That's still pretty low. How much?
It's like 1%.
1%.
Yeah.
Yeah, 10% would be about 150,000, so that's about 1.3%, something like that.
So go to Medicaid.
It's not 9%.
It's even lower than 2% of the beginning. Yeah, just let's look at Medicaid. Because that, we know that Medicaid percentage is higher than the state average.
Medicaid, right here. It is higher. This is more like 3%.
You'll need to expand that, Paul, that,
Oh, underneath that one?
yep.
Yikes. There it is. It's higher than 3%. So between,
That's about 3.5.
Right.
It's still significantly lower when we do account for the drug.
So I agree, Raj. I think that's a compelling question to better understand what the disease
Mhm.
prevalence algorithm is that says this is the asthma population.
yeah, what makes an asthmatic?
Right.
Exactly. We're using, in this case here, codes from diagnoses, et cetera. One other way to look at this might be to look at the episodes that we've got in the data set.
I just had
Oh.
a brainstorm. I wonder if the asthma algorithm even looks at pharmacy.
Right, that's what I'm thinking.
Okay,
Yeah.
so if the disease prevalence is only looking at medical claims, it would be missing the in control asthma patient who only is getting refilled medication.
Right.
And not seeing the doctor or going to the ER for asthma.
And that would be a maintenance drug, so you might not actually have the.
That's what I'm saying. Right.
Well, let's look at this a different way. Let's look at it
But
by
I will
episode.
I will have a takeaway to follow up on that.
This is not trying to say that this is right, it's just we don't understand the gap, and if we can explain the variance, then we are fine.
Right. I suspect that
I think that's
if,
what it
if
is.
that disease prevalence algorithm is only looking at medical claims, you are looking at only patients who are seeing the doctor for asthma and not getting any of the members who are on maintenance medications and never having a problem.
But for a whole year, what I'm wondering is, do they see a doctor once a year?
I don't know any asthmatics, and I'm not one myself, so I don't know.
Once a year, for the research, that's what I thought, because those prescriptions do expire after 1 year. Right, that's right. Yeah, it's not like make a phone call and get a renewal, so it's worth investigating,
Yeah.
just to understand.
Yep.
Because if we can understand the variance between these numbers, we'll understand a lot more what we can do this.
Right.
Okay.
Paul, who would be the best person to ask about
Whether it's included?
the disease prevalence condition definitions, whether they include or don't include pharmacy as a condition, as a qualifier?
Probably Patty Goslin, because she helped write them. And I can certainly send an email out and get an answer to that.